So, welcome all. So, today we would be having a lined up session where we are planning to discuss ASH abstracts. First of all, Happy New Year to all of you and um, hearty congratulations to the EB team, which has done fantastic job in the last few months. We have witnessed great academics, community engagements, workshops, and most of us have enjoyed online teaching sessions, and it's been a very wonderful last 2 year that the EB team of national chapter has done. So with this, uh, I'll just talk about today's session. So this is the National Online Teaching Program. What we thought was let us do few abstracts from ASH 2025, a quick review of them, and we had four enthusiastic young faculty who have volunteered to present four abstracts, and we would have uh, esteemed chairpersons to discuss. So first of all, to introduce today's chairpersons, so we will have Professor Banavali sir, ex-director TMC Mumbai, director academics, and past president of PHO chapter. Satya sir, welcome for this session, and sir will be taking over as the chairperson of the IAPPHO chapter from now. Shweta ma'am will be the current honorary secretary for the PHO chapter, Shweta Bansal ma'am, and Manas Kalra sir. So with four chairpersons, we would have four enthusiastic young faculty who will be presenting. Himanshi, if you can just put on the slide, project it. So we have Dr. Prakruti from Kidwai Memorial Institute of Oncology, Bangalore. Dr. Shalaka, who is just joined NCI Nagpur as a faculty in PHO. Uh, Dr. Swati, who is an associate consultant in Fortis Gurugram, and mm, um, yeah, so Dr. Ruchi, who is the assistant professor in pediatric oncology division at SMS Jaipur. With this, I'll hand over to Shruti ma'am to just open the stage for the presentations.
Thank you, Vinay. And I would like to thank Vinay for putting in all the hard work for arranging the session. And he's been such a great support, all this while. So today we have all, four young, brilliant ladies who will be presenting different ASH abstracts. And we have tried to diversify, take some benign hematology abstracts and some malignant hematology. And I hope these would add to our current knowledge and will be, helping us change our practice. And before I start with the first presenter, that's Dr. Prakriti, I would request all of you to please fill in the feedback form for the last 2 years of national training program sessions that we have had. It will be great to know how Vasudev and Vinay fared and how useful these sessions were for you. And it will be good for the next team who will be taking over about what topics you want, what is the format that you want. So just take out 2 minutes and fill the survey so that it's useful. The whole session and the whole exercise is useful for all of us. Thank you. And with that, I would hand over the mic to Prakriti. Prakriti, please present your abstracts and then we'll take some quick questions.
Ma'am, it says somebody else is sharing, so they need to stop sharing.
Himanshi must be sharing, no?
Yeah, I'll try it now. Yeah, I'll try it now. Is my screen visible?
Yes.
Okay, one second. Okay. Good evening to one and all. I thank the organizers for this opportunity. The first topic is on lymphoma. So this was a paper by Jessica Hochberg and colleagues on targeted immunotherapy in children, adolescents, and young adults with newly diagnosed classical Hodgkin lymphoma, a single center experience from New York Medical College in USA. So the study duration was for a period of 13 years, and inclusion included mainly newly diagnosed classical Hodgkin lymphoma, age range being 3 to 39 years of age, and early stage was all that was mentioned. Now, in the methodology, the eligible early stage patients were given 2 cycles of brentuximab BV-AVDR. That is, BV stands for brentuximab, AVD is the chemotherapy, adriamycin, vinblastine, and dacarbazine, with rituximab given as 4 doses. After 2 cycles of this cycle, there was a PET response assessment done, and they were classified either as rapid early responders or slow early responders. A PET negativity was defined as a dual score of 1, 2, and 1, 2, or 3. And post response assessment, these patients received an 2 to 6 cycles of similar chemotherapy initially, but later on in their subsequent follow-up study, they have replaced adriamycin with nivolumab, so bringing the cumulative dose of adriamycin to 100 mg per meter square. And radiotherapy was indicated only if it was high risk with slow early responders initially, and subsequently only if there is a residual disease at the end of treatment completion. The results of the study or the abstract was there were 54 patients, 34 on the initial BV-AVDR arm and 20 on the subsequent study. They have reported a response rate, a complete response of 100% with early PET negativity seen in 87%. Only 4 patients required RT, and EFS and OS was 100%. The median follow-up being more than 90 months. However, it ranges between 2 to 159 months. Adverse events reported were interestingly seen in only 4 patients, with making it up to 7%. 2 having neuropathy, 1 allergic reaction, 1 mucositis. None had infectious complications. They have also looked into the immune profile 18 months post rituximab and was found to be normal. Now, with regards to validity of the study, it was a 13-year study and only an observational study. Single-centric small numbers are kind of the negative points about the study. Inclusion criteria, long-term effects of these immunotherapy are not mentioned, and there is also no details on the stage distribution and the outcome based on the stage. Utility, if we look at it, 100% outcomes with minimal toxicity looks to be very, and it is very promising. Why wouldn't we want 100% outcomes with minimal toxicity? But there's always a but. First question is feasibility. Among feasibility is availability. All the drugs are marketed in India, which is a good thing, and there is no hassle of importing the drug. Accessibility, however, is a question mark considering, Hodgkin lymphoma is treated in tier 2 cities also. Now, the most prohibitive among all would be the cost, because that is the cost I have put across that we have in Bangalore. And so, what it simply goes on to say is 1 cycle of this BV-AVDR would be equal to around 170 cycles of ABVD, considering ABVD is still the maximally practiced chemotherapy cycle. However, considering if these children don't respond or there is a relapse, and then if there is a need for transplant, the supportive care involved for these chemotherapy protocols, don't know. Probably the chairpersons will be able to enlighten us on that. Now, with regards to applicability in the Indian setting, this I quote from the IMPOG studies. What are the outcomes with the current chemotherapy protocols? Now, in early stage, an EFS of 94 and OS of 95% has been reported, and in advanced stages, EFS of 81 and OS of 91%. This is with an ABVD plus or minus RT background. So considering with such outcomes, would we still want to go in for something which is so expensive? And there is also an IMPOC study which is looking at the real world data on immunotherapy. I think Dr. Amita Mahajan is the PI for this, and they are looking in a retrospective manner what the current usage of immunotherapy is. I just found an abstract in the PHOJ where they have reported their outcomes with nivolumab, and it is a small number of 40 odd patients with a median follow up of close to 30 months, where their EFS and OS was 92 and 95% respectively. And the authors have concluded that nivolumab alone or in combination showed impressive response rates, but this was mainly in relapsed refractory disease. I think of the odd 40 odd patients, only 4 patients it was used in an upfront setting. It was well tolerated, and lower doses with significant cost implications appear to be equally efficacious. Now, one more factor which would be brought into would be the infection risk, but because we are all well aware that the kind of infections that we face are very different from what the Western world does. And is the Indian lymphoma biology same as that of the Western? Would response also depend on the stage and other clinical features, and whether the cost being a prohibitive factor will not be so with generic drugs in the horizon? With that, I close my presentation and over to the chairpersons.
Thank you, Prakriti. I think we would like to ask Banavali sir and Dr. Yadav sir about, sir, where do you see this in our Indian background, setup? Do you think there's any role of upfront immunotherapy, or will it be the future, and in what subset of patients?
Thank you, Prakriti. First of all, thank you for choosing that abstract, which is very, very important abstract. We always in India complain about, whenever we start something new, that this is not FDA approved or DCGI approved, or there is no, publication for that and all. But imagine this, in USA, they're doing this 13 years back, they've started doing things when it was not even standard of care. Even today, actually, nivolumab is not even standard of care for newly diagnosed non-advanced patients with, Hodgkin's. So basically, they have been doing it when it is not standard of care. So one thing is that's really good that you can do something different if you think it's going to be efficacious. So that is one thing. I think personally, if you see, I think that cost and all which you showed probably is secondary, because I don't even think brentuximab will be required. If you see our data and even the newly published data of nivolumab, it may be that you may not even require to add brentuximab. So maybe you can from the first cycle, because that time nivolumab was not available. They started using it when it was not available. So they started with brentuximab. They added nivolumab once it became available. So that's one thing. So nivolumab, again, the second thing which you quoted, our study itself, and we have been using it now for the last 2-3 years now, the low dose nivolumab, 40 milligram, which we ourselves published in head and neck before, and now in even Hodgkin we have published. So 40 milligram, which brings down the cost to 40,000. But even the newly introduced checkpoint inhibitor like Intasys introduced the serplulimab, the Chinese one, which cost 12,000 maybe. MRP is 18, but 12. So the cost will come down, and if you consider that, it may really bring down the cost of the immunotherapy also. So, and the second thing I feel is that all the chemo they've used also is overkill. I require this much chemo. It may come down even more than that. So I think this is the future. I mean, be ready for it. And when that's why yesterday we had a session in Tata in our teaching this thing of treatment of relapse refractory Hodgkin's. I think that's going to be a thing of the past. That we may not even talk about refractory or relapse in the next few years. So I think this is going to be future. What to use, how to use, all that it's a thing in progress. So things will change. Even this, what I feel, the present protocol is overkill. It may come down even more than that. But I think the addition of rituximab is a master stroke. I personally feel that that along with that may have increased, because it has changed the tumor microenvironment further. And I think that all this overall, this is a very good this thing. But infog, this thing our group may have to do as studies, but I think it may take 2 years to do what it has taken for 13 years for them. So I think that's future. So overall, I think it's a great this thing, and it's in making. I don't think exactly this will be the future, but some of it will be there. Immunotherapy with maybe rituximab plus some chemotherapy, but brentuximab may not be required also. That's what I feel personally.
Yeah.
But thank you for a great presentation.
So just one comment. I agree with Dr. Professor Banavali that what he has highlighted, that this is the future. And brentuximab versus your nivolumab, there was an RCT in ASH this year in adults, and they showed that arm which gave nivolumab did much better than your brentuximab. So nivolumab is clearly the winner, and more we introduce it, whether we give brent or not, doesn't matter. That's I think, the main thing in the protocols now.
Yeah. And
Thank you.
not only adult, Satya, it was
Mm.
from 15 years onward. So it
Yeah,
included pediatric patients also.
absolutely.
So since you mentioned about rituximab, there is a question in the chat box about what is the rationale behind. You mentioned about altering the microenvironment. Can you please explain it a bit further for the benefit of our residents and
It's for me or Prakriti?
for you, sir, for you.
Okay, great. So, this is anti-CD20, so it affects the B cells. And I think the tumor microenvironment plays, the Reed-Steinberg cells per se are very, very few. 1:20, 1:30 is what usually the cell of our Reed-Steinberg cell versus the other cell. So the Reed-Steinberg cells are very few. The other cells are there. So I think rituximab is targeting the CD20 cells, which change the microenvironment to a certain extent. And I think that when you do, and EBV is also there, it's part of this thing. Many of them are EBV related. So just now there's a new paper where they've shown that EBV, basically, I think it's there in today's presentation only of if you give it before the conditioning, it has changed the EBV infection. So overall, I think it's a great this thing. It may have helped them to decrease the infection rate also in this thing. Plus, change the tumor microenvironment, so your immunotherapies have worked better. So your T cells and this thing may have got an upper hand. So overall, it is a thing that has worked to our advantage and decreased overall, I feel, because there's no relapse also. Up to 159 months was what I think you showed. So there are certain patients who are for a very, very long time, still there has been no relapses. So I think overall that's a great strategy, I think, which is a master stroke in this whole protocol.
Thank you, sir. And I would request Dr. Vinay to introduce the next speaker.
Yeah. Thank you, Prakriti. Excellent presentation. Thanks for the discussion. So as we move on to the second abstract, I would like to ask Dr. Ruchi Chowdhury. She is assistant professor in pediatric oncology at SMS Jaipur, and she would be talking on a benign hematology topic. One of the common cases we see in our OPD, newly diagnosed ITP, the use of Eltrombopag versus standard of care. Over to you, Ruchi.
Thank you, organizers, for giving me this opportunity. So, yeah, am I audible?
Yes.
Okay. So I'm going to talk about the PINES trial, which was a phase 3 randomized trial. And this was done in all the newly diagnosed patients of immune thrombocytopenia in pediatric patients. And so, my screen is, yeah. So this was basically a prospective open-label randomized trial, and the study was conducted in USA in 23 centers, and this was sponsored by the ITP Consortium of North America and
Can you go to the presentation mode, Ruchi?
Yes,
not
yes,
in slide mode. Yes.
Yes.
Convert into slide mode.
No, yeah. So basically, they included all the patients of ITP who were less than 18 years old, all the primary ITP patients diagnosed from 3 months from the diagnosis, less than 3 months from the diagnosis, and who had less than 30,000 platelet counts. They excluded all the patients with severe grade 4 and grade 5 bleeding and all the cases of secondary ITP. And their primary objective was to assess whether the platelet response, which they defined as more than 3 times on 4 occasions, which on week 6, 10, 8, 6, 8, 10, and 12 of the therapy, whether the patient had sustained platelet count or not. They had multiple secondary objectives also, which we will discuss later. So these were the working definitions used by the group, and they randomized the patient in 2:1 groups, and they included all the patients of newly diagnosed upfront, those who were receiving upfront treatment, or the patient who failed the treatment also for the first line therapies, but less than 3 months from the diagnosis. So there were two arms, L-Trombopag versus standard treatment choice. In standard treatment arm, in which the treatment was decided by the investigator, and then they assessed the patient. So this was the assessment method they used during this study, and the results were, so these were the patient demographic. 78 patients were registered in the L-Trombopag arm and 40 patients in the standard therapy arm. And both the arms were almost similar in their baseline characteristics. But as we can see in the race and ethnicity, only 3 patients in each arm were from the Asian race. And the prior therapy was not given in 66 cases, and rest of the patients who received were already had one line of treatment. So these were the outcomes. So the primary outcome in the study was the sustained platelet response, which was quite significantly high in the L-Trombopag arm. 65% of the patients with the L-Trombopag arm showed the response, and that was between 6 to 12 weeks. They had consistent high platelet count versus 35% patient in the standard therapy arm with a p-value of 0.002. And the secondary outcome, which was the rescue therapy needed. So rescue therapy was needed in 17% of the cases of L-Trombopag arm versus 38% cases of 38% patients of the standard therapy arm. And the difference were again quite significant with a p-value of 0.009. And the rest of the indices, including bleeding score, iron and hemoglobin indices, were almost similar. And the health-related quality of life index was slightly better in L-Trombopag arm. So basically, the response were transient in the standard therapy arm, and improvement in the health-related quality was slightly better in L-Trombopag, and there were lower likelihood of receiving rescue therapy if you are on L-Trombopag arm. And the exploratory outcomes, they assessed whether the platelet counts, how frequently the platelet count rose. So as you can clearly see in L-Trombopag arm, it was the mean duration of 35 days when the platelet count crossed 30,000 of the cutoff, and it was 21 days in the standard therapy arm. So standard therapy arm showed quite significant results, and that was early response. So this is the bar chart which shows when the registered the patients. L-Trombopag arm patients had slightly higher bleeding scores, but the bleeding scores stabilized by the week 2, and almost less than 10% of the patients in both the arms had higher bleeding scores after 4 weeks. And in this, this is the L-Trombopag arm, which shows that the number of rescue therapies needed in initial 2 weeks were slightly higher in this arm, but after that, barely a few patients needed rescue therapies, while the rescue therapies were needed in standard therapy arm. So this is another chart, which is the KIT tool they use to assess the parent proxy reported KIT score. So the parent proxy reported KIT score was initially lower in the L-Trombopag arm, but it improved significantly by the 12 weeks of duration of the study. And this is the curve which shows the consistent sustained rise of the platelet in L-Trombopag arm, while the platelets were fluctuating in standard therapy arm. So by 1 year of the study, 106 patients completed the study, which were 94% in the L-Trombopag arm and 83% patients in the standard therapy arm. And they found that 45% patients had disease resolution in L-Trombopag and 52% and the difference was not significant. And the primary remission with single drug of L-Trombopag, 45% patient had remission, and in the standard therapy arm also, primary remission was 45%. And sustained response was seen in 56% of the patients of L-Trombopag arm and 61% of the patients of standard therapy arm. So these were the major conclusions from the trial, that overall 47% patients had disease resolution, and there was no difference between the arms, with sustained response of treatment was 56% in L-Trombopeg and 61% in standard of therapy. And initial response was quite significantly higher in L-Trombopeg arm, which was between 6 to 12 weeks. So now coming to after these results, coming to the validity of the study, as this study seems quite lucrative, as between 6 to 12 weeks, the patient had quite good response in the L-Trombopeg arm. So was the results biased by a bit of financial conflict of interest of Novartis, or as this was an open label trial and the initial therapy, which was the standard therapy, which was dependent on the investigator, so it could lead to the investigator bias also, and the numbers were insufficient for the subgroup analysis, and patients with the severe bleeding were not included. So we cannot extrapolate these results to the entire population of all the newly diagnosed patients of the ITP. And about the external validity or the applicability of the study, as we can clearly see that the sustained platelet response was quite good in L-Trombopeg arm. So this could be of real importance in Indian context, where follow-up might not be adequate, and we might be able to avoid the initial bone marrow examination also, as L-Trombopeg might not affect the bone marrow results much. But in this study, only 6 Asian patients were included. So we might need further evaluation, as I couldn't find much studies from, as this is one of the first study which has compared the results, but what is the response in our population, that we are not certain of. And what about the cost effectiveness and the quality of the drug in the Indian setup? I could find these are the drugs available in Indian market as compared to the Revolut, and which seems quite cheaper. So this might be cost effective, but what about the quality of these drugs from different pharmaceutical companies? So this I have bare minimum experience. So I might ask the chairperson to show some light on this, whether this is feasible in our setup or not. Thank you.
Thank you, Ruchi, for that presentation. And you've highlighted a very important point, that how applicable it is. Now, I would request Dr. S.P. Yadav and Dr. Shweta Bansal to give their comments, especially on 2 aspects. How often do you treat your newly diagnosed ITPs, and what are their criterias, and bone marrow examination? Like, one of the factors which was given was that L-Thrombopag can, avoid a bone marrow, but how often are we really doing bone marrow examinations in today's date?
So, excellent presentation, Dr. Ruchi, and very interesting study. So, the never-ending debate on bone marrow versus no bone marrow. Every FOCON, we spend half an hour or 1 hour. We can spend an entire day also on this. So, I won't discuss it much, but I will tell you that it's not a must to do a bone marrow in a case of ITP with the present day. Like immature platelet fraction, good peripheral smear, and a classical history, you can treat an ITP patient without a bone marrow. So that's my personal opinion, but it is debatable. People have pros and cons of doing bone marrow. So let's leave it there. Now coming to this study per se. So Eltrombag is a costly medicine, and giving it for long time is definitely a burden for most patients in India. And ITP, as we all know, the best treatment is no treatment. So not every patient needs treatment in ITP. So there should have been one more arm where patient got no treatment. And how did they do? Or what was their natural history? So the comparison is not very good, because in the other standard of care, you usually treat with IVIG or steroids, and you treat just short term, like steroids for 2 weeks, IVIG just 1 dose. And most patients, they never have recurrence. Their platelets stay good, or they drop a little, they come up, but they don't have any bleeding or any problems. So, like the failure rate was just 38%. That means 62% patients were very good. They were doing fine. There was nothing extra required. So why expose them to another drug for such a long time, which was anyway not needed, Eltrobag, in most patients? So in our practice, I don't think this is required. It may be for a subset of patients who have, despite being treated with the first line drugs, they are again and again coming to the hospital, platelets are staying low, and they have bleeding. associated with low platelets. So those are the patients where Altromag might be a good option. So this study shows that this is an effective drug, but we don't have to give it to everyone in our practice. Our standard of care drugs are still good choice, and we just treat for short term and then they leave the patient because most patients don't bleed and they do quite well. That's what my take. Over to Shweta.
Thank you, sir. I think you have highlighted all the important points. But one is congratulations to Ruchi for taking up this study and discussing this. So I have 2 points to discuss over here. One is that this is a very simple study. It is for the fellows how simple studies can be taken up in ASH also and can be presented. So the whole, the design of the study is very simple and can be done easily in our setup also. So I think fellows should take up inspiration from this kind of a study and should work on these kind of questions. Now, second point is that definitely what Dr. Yadav has also highlighted. I think some of the patients over here are overtreated. The kind of the criteria which they have put over here is that the platelet count more than 50,000 over certain time. We don't need this kind of a criteria for treating the ITP patients. Our ITP patients, we mostly treat those patients who have counts less than 10,000 or 20,000 or who have a bleeding. Mostly we always counsel the patients, and has been a proper standard practice for us also, that we don't, until and unless patient is bleeding or his platelet count is less than 10,000, then only we treat this patient with some kind of a therapy. So, with this rationale, I think we should stick to this and we should design the studies properly, because cost of therapy is also important. And when if the primary ITP who comes to our institute, or when I do a practice, I mostly see these patients how active or how okay they are, and accordingly we decide the therapy. And if you see in this also, there is many of these patients who are Eltrambo they require some kind of a rescue therapy initially. So the rapidity of the response is also very important. So maybe we have to, so the patients who don't respond so well, maybe they require kind of a dual therapy in which IVIG and steroids can be the first line of treatment, followed
Something
by
went wrong. Please try again.
so once we have done the first line of treatment, then if we have to have a sustained response, then Eltrombopag can be added. So, these are my thoughts on this kind of a study. Yeah.
There is a question in the chat box. Is there any difference between generic drugs or other, the research molecule? Any experience with that, and what is the risk of thrombosis if you have seen any? I have not personally seen any thrombosis, but I would like to.
So no, we are using it and we are using it in very small children also. We haven't seen it is a very safe drug so far, and it is very difficult to say the generic drug or which one is better, because then we need a proper study, proper pharmacokinetics. But so far, as per the clinical experience, we haven't found any issues with that. Yeah.
So just one point, you have to monitor liver function test, LFTs, and if they get deranged, then stop Eltrovag. That's something which people should keep in mind. Otherwise, it's a very safe drug, no thrombosis risk per se.
Yeah, but sir, I think all of us here have a responsibility of saying it that you don't need to treat every patient with ITP, because otherwise we'll have every primary ITP coming to us, whether the child is on L-thrombopag or romiplastin. So I think that's a message that should go from our side, from the PHO community, that don't treat every child, don't just look at the counts and look at the patient per se, right? So I think that's the important message that should.
Ignore ASH abstract for.
Okay, know when you have to use L-thrombopag. That's what I would say. Just know how to use. Banavli said, I think you're muted. We can't hear you.
Sorry. Was this an oral abstract or a poster presentation?
Oral abstract.
This was an oral abstract?
Yes, sir.
It's
Okay,
pharma
because
driven. The pharma wants to sell Eltrovag.
absolutely,
Yes, sir. Yeah, that's what it seems.
because a non-randomized study, this thing, to get an oral abstract is great. They would, if it was an Indian study, they would not even have considered it for this thing. Anyway,
Absolutely. And even the design of the study is also, endpoints are also not very well
very,
defined.
very this thing, very.
Thank you. And I think we'll go to the next abstract.
Yeah. So to the next abstract, Dr. Swati, she's the associate consultant in Fortis Gurugram. So she'll be speaking on the use of utility of prophylactic rituximab administration in a huge cohort of patients to prevent EBV reactivation in allotransplant. Over to you, Swati.
Yeah, good evening, everyone. Thank you so much for this opportunity. And I've been bestowed upon with the abstract in the allogenic transplant conditioning regimen segment. And it is a very important abstract highlighting the prophylactic rituximab on day -1 during conditioning, which significantly reduces the early EBV reactivation. And they did a real world evidence. The abstract is coming from Dr. Senlin Zhang, and this is a Chinese cohort. And they have done a lot of studies on preventive care, which is a very important segment in our transplant section. So coming to the background, Epstein-Barr virus reactivation is common, a serious complication, and it contributes to PTLD and non-relapse mortality. Preemptively, in the case of EBV reactivation, we use rituximab, and different studies have highlighted different time point usages, like prior to HSCT in 6 months or after HSCT on day +5. But the efficacy during conditioning has not systematically been studied in children, particularly on day -1. So they did a retrospective analysis of pediatric patients over a 15-year period. They used rituximab during conditioning and defined their primary endpoints, whether rituximab in a dose of 375 mg per meter square on day -1 reduces EBV, and studied the secondary endpoints, including neutrophil platelet engraftment, transplant mortality, and immune reconstitution. So they got very amazing results. In the 834 pediatric patient data, they characterized at 200 matched pairs. The EBV reactivation was significantly lower in the rituximab group. In a multivariate analysis, they found that the rituximab was independently associated with that reduced risk. Among the patients, those who had EBV, the rituximab had lower initial peak, ranging up to 11,400 copy numbers. Additionally, rituximab also associated with faster platelet engraftment, and there was no difference in the overall survivals, engraftments, GVHD, or CMV reactivation. And most importantly, the immune reconstitution was transiently delayed in the rituximab for the first 3 months, but showed normalization thereafter. That's why they have highlighted the transient point. So the cohort concluded that the prophylactic administration of rituximab on day -1 during conditioning effectively reduces EBV reactivation, gives an additional benefit of decreased viral bloom, and additional blessing of early platelet engraftment in pediatric allogenic HSCT. So that's why they have promoted this approach with its efficacy and a feasible prophylactic option instead of the usual preemptive option that we follow. So the utility of the study is definitely good in terms of the problem of EBV reactivation, because it was significantly lower. There was lower morbidity, lower PTLDs, which is a life-threatening problem. There were lower initial peak viral loads and an associated faster platelet engraftment. The validity of the study is to be highlighted. It is a retrospective analysis, definitely, but they had 200 matched pairs, which are good numbers, and a matched pair analysis is a good design of study. But the comment on the type of transplant, EBV status pre-transplant, HLA mismatch, GVHD status is yet to be studied further because the full paper is yet to be traced. Coming to the validity in other papers that have been studied, the recent papers in last 5 years have found similar results, that the EBV reactivation is reduced and at any time if you have used rituximab within 2 weeks before transplant. Also, they have found that PTLD risks are lower if any time rituximab is used prior to transplant. But we have to take this with a pinch of salt and realize that a rituximab on day -1 is to be weighed according to the point that who is at risk of this EBV reactivation. As is it necessary for all to undergo this day -1 additional rituximab? So definitely an in vivo or in vitro T cell depleted transplants, including ATG uses, alemtuzumab usage, or EBV serology mismatch, a second HSCT, a TCR alpha beta depletion, severe GVHDs, CMV reactivated transplants, these are at risk of PTLD. So definitely these patients should be selected for this additional prophylactic option. But having said that, studies have also highlighted that even if we are faced with the problem of EBV reactivation and not transforming to PTLD per se, a reduction of immunosuppression is good enough an approach, and you might not actually worry about giving those rituximabs. So what worries us? Why not just take this approach in high risk and in low risk population? So definitely our worry is always infection. And it has been studied thoroughly that bacterial infections have increased, there is an increased risk when the rituximab was preemptively or prophylactically used. This is a 2012 very nice paper from Transplantation Journal. And a recent paper also highlighted that rituximab toxicity when used preemptively or therapeutic is manifested as a higher incidence of severe neutropenia. And they have also highlighted the concept of late onset neutropenia with rituximabs, which manifest at 3 to 24 months. So that is like a fragile time when the care has gone a bit down, the parents take things a bit lightly, the follow-up rates have increased, but a neutropenia manifesting at that time may cause fatal infection and contribute to the overall mortality. Also, the survival worries us, but it has been studied that a preemptive rituximab does not affect the survival. So thanks to that. So what are the other ways to tackle the problem of EBV reactivation that the cohort has highlighted? There have been different approaches, including day minus 8, day minus 1. But the more common used approach in previous studies was day plus 5. And a different dosages have also been proposed, which is 150 mg per meter square, a maximum of 200 mg. And a 2024 analysis found reduced EBV infection and EBV PTLD and improved survival with this approach. So what is pros and cons about the two approaches? A day minus 1 approach has a scientific basis of depleting the recipient B cell reservoir before the graft is infused. So there is a zero risk to the donor B cells because they are not in picture yet. And the B cell aplasia has a similar delay as highlighted in this study. With a day plus 5 post-transplant approach, which has been highlighted in various other studies, they say that they deplete any B cells which remain after conditioning or within the donor graft. So they directly attack the donor graft, which may lead to a prolonged B cell aplasia, but then have been found to be equally efficacious. So there have been proposals of low dose rituximab to tackle this problem as well, but that has been used as preemptively. So a prophylaxis of low dose rituximab would be a project worthy thing. So talking about the feasibility, for a 30 kg kid, an additional rituximab would cost about 10,000 max, and cost of IVIG, assuming that the child needs IVIG after that B cell transient aplasia happening, would be 35,000 per dose. Versus if a EBV reactivation happens and reduction of immunosuppression is not able to tackle that problem, a 4 minimum doses of rituximab would be an additional cost burden. There will be cost of biopsy to prove those PTLDs, PET scans, morbidity and mortality, and that would be a big problem. The feasibility is that it is easy to administer. We can, however, avoid steroid pre-med with Ritux on day minus 1, especially in the haplo setting. It requires a basic training for rituximab administration. The side effects are minimal, infusional reaction, and we've been using this on day minus 1. It is a rest day in many protocol, so it does not prolong effectively the hospital BMT stay, and we can adjust this one additional day. So weighing the pros and cons, prophylactic rituximab, which the cohort has proposed, is definitely a good practice, but can be taken up in high-risk population. And a larger study in the Indian setting with our supportive care that we practice and our high-risk population, and maybe exploring low dose in the prophylactic setting as a RCT would be useful.
Thank you, Swati. Thank you for giving an elaborate uh, review of literature of this study as well. And now I would ask the chairpersons first to Satya sir, and then to Shweta madam. What are your comments and what is the utility and how has been the practice of using rituximab in our conditioning regimens?
So, congratulations, Dr. Swati, for a wonderful presentation. Very crisp, and the review of literature was wonderful. So, this study is definitely a good study. It tells you something very, very simple that one dose of rituximab can prevent EBV reactivation in a transplant setting. And the data is very, very convincing. Now comes the second part. Do we need to change our practice based on this? So I would say no and yes. So no means it is not a universal application because match sibling donors to develop PTLD, EBV induced, it is extremely rare, extremely rare. So you may not be preventing a lot of PTLDs by giving rituximab in match sibling setting, and you may be increasing the cost by the need of IVIG post transplant more and more risk of infections in a straightforward transplant where PTLD risk is very little. So match sibling should possibly be kept out of it at this point of time, unless there is a data in match sibling also. Then the second part is the high risk transplant, like TCR alpha beta, or you have a cord transplant, or you are doing haplo transplants where GVHG rates are going to be high, like with PTCY and all. Then I think it's a good idea to add in them and to prevent the reactivation of EBV and PTLD because the risk of PTLD is higher in these type of transplants. So in our center in haplo transplants, we are routinely doing it using one dose of rituximab. We are not doing it in day -1. We are doing it right at the start of conditioning, like day -7 or day -8. And we haven't seen any EBV problems in our cohort of haplo patients, but we haven't published our data as yet. But it's definitely a good study and it has a lot of applications. So it may change practice of a lot of people. So these are my thoughts.
Okay.
Thank you, sir. Shweta ma'am, for your comments.
Not much to add, but I'll just share my experience with this rituximab. So recently we used in one of our patients for haplotransplant, and these patients they have severe immunosuppression. We all know, and they have a profound T cell immunosuppression with it. So in that patient, when we gave rituximab, we used rituximab two doses. One is the like almost 2 weeks before the start of the conditioning, and one is just before the day -1 we used it. This patient, post transplant on day 30, developed a Giardia lamblia infection, which is like more common we see in CVID kind of a condition. And that infection was resistant. So, what Swati has highlighted in her presentation also that we have to use this very judiciously in our patients, and we have to be aware of the side effects which can occur because of the use of rituximab in certain patients as well. But I think it's a good drug. It not only counters the PTLD and EBV reactivation, it also helps in improving the GVHD rates also, because we all know that T cell only is not responsible for GVHD, B cell is also equally responsible. And when we are doing the T cell deplete transplants also, in which we are doing a TCR alpha beta depletion only, and we are not doing CD19 depletion, for those patients, rituximab is a must to be used. But these things should be kept in mind when we are using it. That's my take. Yeah.
Thank you, ma'am. Manas sir, what has been your experience in using rituximab uh, as a preemptive prophylactic treatment? Are there any additional advantages in form of avoiding immune dyscrasias in multiply transfused thalassemics or aplastic anemia? Would there be additional benefit of rituximab in such scenarios apart from just decreasing the PTLD rates of EBV?
Hi, Vinay. Sorry, I'm traveling somewhere. So,
Okay.
my connectivity has been patchy, and that is why I kind of logged off twice in between. But I heard Swati's presentation intermittently. My only main comment for this study was, infection. Because I think that has to be very carefully looked at whether the infection rates with rituximab are more or not. The other thing which we need to look at is the dose of rituximab because most of us have kind of just blindly followed the lymphoma dose. And there are many papers where they have used like a 200 mg per meter square kind of a dose or an absolute dose, which has led to, kind of similar results. So these things need to be studied further. As far as immune dyscrasias are concerned, because the B cell amount is less, so some of the autoimmune manifestations are bound to be less. But I Personally, we use it for all the high-risk transplants like the TCR alpha betas and the other haplo transplants. Wherever we feel that, PTLD is going to be a big issue, we do not use it for the matched sibling donors. But I think these things need to be prospectively looked at: the dose, the infection, and probably the lesser amount of immune dyscrasias in these patients. Thank you.
Thank you, sir. So I think we'll move on to the next presentation. The next presenter is Dr. Shalaka. She's a assistant professor. She's a consultant pediatric oncologist at NCI Nagpur. So over to you, Shalaka. She'll be speaking on the use of Vaseline medicated gauze to avoid to improve mucositis. Over to you, Dr. Shalaka.
Thank you so much, Vanessa. So we move on to the next abstract. This is a basic abstract in supportive care. So the title of the abstract was a prospective non-randomized controlled study of Vaseline medicated gauze for topical management of chemotherapy-induced oral mucositis in pediatric hematology patients. This study was conducted at Beijing Go Broad Hospital by Jing Pan and colleagues. So the background of the study was that chemotherapy-induced oral mucositis, as we all know, is a severe complication of especially high-dose chemotherapy. It leads to increased risk of secondary infections, more treatment interruptions, and pain along with poor nutrition. With the current interventions, the rates of healing are comparatively slow with limited pain relief. So, this particular study evaluated the efficacy of Vaseline gauze loaded with a compound powder for improving the CIOM healing and pain control. So, their study design was a prospective non randomized control trial for 1 year duration. The total population was 60 patients. The inclusion criteria involved 2 to 12 years of age with a grade 2 or more CIOM. The intervention group consisted of 40 patients, wherein the intervention was application of Vaseline gauze dipped in a compound powder consisting of antibiotics, vitamins, and antivirals. The gauze, they trimmed it to match the ulcer morphology and ensured complete ulcer coverage. This gauze was applied twice daily on the ulcerated area. Against this, the control group consisted of 20 patients, wherein they just used a basic sodium bicarbonate mouth rinse, which was applied 4 times a day, and it was to be used for more than equal to 2 minutes per rinse. So the outcomes were defined very properly. The primary outcome was time to mucosal healing, which was defined as a sustained WHO grade 0 response. And the secondary outcomes were pain reduction, safety, and adherence. All of this were evaluated at 48 hours post-intervention. The key results in their study was a median healing time of 3 days for the gauze with the use of Vaseline gauze against a 7-day healing duration for the control group. So there was a 57% faster healing with the Vaseline gauze medicated with the medicated Vaseline gauze. As for the pain control, as well, there was a 128% greater relief with 4.8 points of pain relief on the scale with the use of gauze. There were no adverse effects reported, and the adherence to the gauze was 93.5% against the rinse, which was 67%. This is a meta-analysis which has compared various various interventions that are being used over the world for treatment of chemotherapy-induced mucositis. In this analysis, with regards to decreasing the duration of mucositis, honey has been proven in a lot of studies to be the best available alternative. And for decreasing the pain, olive oils, I'll just highlight it here. Not able to do that. So olive oil has been seen to be the, so here. So with regards to decreased duration, we see the light blue thing that honey has been proven to be the best available option. And with regards to decreased pain, olive oil, the green part, shows that it has been maximally effective. So they concluded in this study that Vaseline medicated gauze accelerates healing, provides rapid pain relief, doesn't compromise safety, and ensures high adherence, and is a novel tool to be integrated in protocols for pediatric CIOM management. Coming to the utility of this study, the clinical impact is it definitely shortens the healing time, thereby needing fewer treatment delays. There is good symptom control, early pain relief, improving nutrition and quality of life. With regards to healthcare efficacy, there is reduced hospital stay, lower infection risk, and there's also a caregiver benefit because it is easy to administer with better compliance. The strengths of this study is that it is a prospective study. The outcomes have been clearly defined on various scales, and the difference in the outcomes is significant statistically. But the limitations of the study are it is a non randomized trial, it is a single center study. The exact composition of the compound in which they have dipped the Vaseline gauze has not been specified. They've just mentioned it to be consisting of vitamins, antimicrobials, and antibiotics and antivirals. And the sample size here is also small. So it is an overall it is a promising study, but requires multi-center RCTs for confirmation. Coming to the feasibility of this study, it is a simple intervention because gauze trimming and application is a low skill requirement. The materials that they have used are also widely available. There are no adverse effects, no safety related concerns, likely to be affordable compared to the advanced mucosal agents such as low dose laser therapy and others. And it requires minimal training, can be easily done by nurses, parents as well. So it is the applicability in Indian scenario. Yes, it can be applied in our scenario. It is a low cost, scalable, can be implemented at regional cancer centers, tertiary hospitals, and it is also culturally fit in the Indian family and involvement. So the future scope is for local trials for validation and potential for rural outreach programs. So the take-home message here is Vaseline medicated gauze is a safe, effective, feasible, and culturally adaptable solution for pediatric chemotherapy-induced oral mucositis, and we need larger RCTs in the Indian settings to prove this further. Thank you.
Thank you, Shilaka. And I think I would like to reiterate what Shweta just said a couple of minutes earlier, that, such an easy paper, and then you can do some studies as simple as this and, be there for ASH presentation. So finally, Banawali sir and all our chairpersons, if you have any comments to make.
Yeah. Again, thank you for choosing this abstract, simple study, doable study. Only thing is, again, this is like a, Ayurvedic, this thing, where they say mixture A plus mixture B plus mixture C. Any of our so-called modern medicine trials would not allow to write a paper without mentioning exactly what it is, because even in that abstract, it's just written vitamins and antibiotics and antivirals. So that's not acceptable, I feel. Whatever it is, we should do, because we use a combination of metrogel plus acyclovir plus folic acid or something like that. And even we had done, like, the bone marrow team had done a study of using curcumin, just application of curcumin. So that had also shown. So there are various means to decrease this ulcers in the mucositis, this thing. But my main this thing was, I couldn't see in that abstract. And Shalaka, if you can tell what was the age of this patient, what was the median age and age. For example, to keep a gauze in a 2-year-old child will be a 1-year child will be nearly impossible. He or she will not keep it, and this thing. So whereas a older child will allow you to keep that gauze in that side of the ulcer. So age would be important. Is there any mention of age in this?
They
This
have
thing?
mentioned in the inclusion criteria, sir, the age to be 2 to 12 years.
Yeah, but you don't know what was the median
Median
age
age,
in this group.
it has not been mentioned.
Because it would really make a difference. But yeah, there are various means to decrease this thing. But this is one of the things which we also have been doing for years now of mixture of, like I told you, the metrogel plus basically acyclovir plus, folic acid or something like that in decreasing, and curcumin that we did. So various means to do it, but simple thing to do. And, but to accept it without writing what exactly they've used, I thought it looked a little, this thing, which at the edge level to accept it without mentioning what it is not the right way to do things in modern medicine, at least, because if you have to repeat it or duplicate it somewhere else, you should know exactly what they did. But thank you for the presentation.
So, not much to comment about. Dr. Banawali has already addressed. So, excellent study, but the composition is the main issue. So, that's all. Thank you.
Thank you, everyone. And think this was kind of a new session for us also to conduct, and hopefully, you found this session
Great.
useful as the previous ones. And the whole purpose was to actually bring forward a lot of newer fellows and consultants to present the study so that they understand the intricacies of how to make a protocol and what are the fallacies of each. So with that, I think I would like to invite Manas. He had a few announcements to make before we call it a day.
But
So,
thank you, Vinay. Thank you, Shruti, for doing this consistently over the last 2 years. So thank you very much.
yeah, the same thing, Banavli sir. So thank you so much, Vasudev, Vinay, and Shruti, who have meticulously, for the last 2 years done a fantastic job. So big thanks to three of you. And we had multiple intense discussions every time a session was being planned, and everybody had their own opinion. So thanks a lot. Big thanks to three of you. Just one small announcement is about the best of PSYOP. So, we will be doing Best of PSYOP meeting on 22nd February. And around 11 or 12 speakers will be there. It will start from 6:30 onwards, and soon you'll get an information about that. And from next month onwards, Dr. Yadav and Dr. Shweta's team will take over the academic sessions. And 22nd January, just block your date for the Best of PSYOP. And we'll have the topmost abstracts being presented online on that day. So thank you so much, and thanks again.
And Manas is going to tell Zomato to send dinners to all those who attend PSYOP. Huh?
Yes, sorry, sir, but I think instead of those who could not go to PSYOP, at least those 2.5 hour sessions will wind it up. So yes, thanks.
It will be great, but thank you again.
I think I would like to thank all the
Thank you,
chairpersons
everyone.
and all the presenters. Please share the abstracts on the PHO group because there have been requests there. And thank you everyone for being there for last 2 years. I think it's been lovely to have 100 plus participants. A humble request, please share your feedback. That means a lot to all of us. Thank you. Good night.
Thank you. Thank you all. Good night.
Good night, everyone. Thank you.